Start. Hello everyone. So today I'll be discussing with you the test and discussion, and the main topic of today will be acid base, anion gap and electrolytes. Believe me, these are the topic which are asked in all the exam, whichever exam you appear in the world. And they are supposed to be one of the most confusing and most difficult. But don't worry, all this I'll make it very simple, and everything what I'm going to discuss in the next 3 hours, I will make you revise in just 1 minute only. Okay? 1 minute only, whole thing what I'll be discussing 3 hours, 1 minute. So before I start, a very happy new year to all of you. I wish you all the best, that you always remain healthy, peaceful, cheerful, happy, and may God bless you all the success. With this, we start with the topic of renal tubular acidosis. Okay. Well, we have a question for you. 54-year-old diabetic male, and he come to you in the OPD, and his potassium is 6.2 millimole, bicarb is 19. Urinary protein excretion is normal. What is the most likely diagnosis? The answer of this question is renal tubular acidosis type 4. Why this the answer? Why not others? That you will not understand unless we know the basic concept about RTA. But before I proceed further, just the few things which are there in this question. Patient is a diabetic person and he has come to OPD. So this cannot be DKA. DKA is a medical emergency. Patient will not walk to you in the OPD. It's ruled out. Second notable thing is here we are getting hyperkalemia. 6.2. We know very well the normal potassium level is 3.5 to 5. So here the potassium is high, so we call it hyperkalemia. And the bicarbonate is 19. And we also know very well the normal bicarbonate with 2 to 28, serum bicarbonate. Low bicarb means patient has acidosis. There are the few keywords which I thought I must share with you before I proceed for the basic concept about renal tubular acidosis. So let me tell you about basic concept about renal tubular acidosis. So here is the nephron. Okay, this is the nephron. And this is the distal convoluted tubule and the collecting tubules, right? DCT and the collecting tubule. What happened normally? First we learn what happened normally, then only we see what happened. So what happened normally? Normally is that here, let's presume aldosterone comes. All of us know that aldosterone come and act in the distal part of DCT and the collecting tubule. Normally what it does, normally is when the aldosterone is there, it will lead to absorption of 2 sodium. And we also know that this sodium is absorbed actively. Water follows passively with the sodium. The 2 positive particles have entered the body, and as per law of electrostat, 1 H ion will go out and 1 potassium will go out. It's mandatory, the law of electrostat. There's no discount, no concession on this particular entity. This is normal. So A for aldosterone. This happens normally. Now in type 4 RTA, the level of aldosterone is reduced. So definitely if the level of aldosterone is reduced in RTA type 4, okay, so less sodium will be absorbed, definitely. less sodium will be absorbed, it means less amount of H ion will go out. So H ion will remain in the body, that will lead to acidosis. And potassium also remain in the body, it will not go out, so that will lead to hyperkalemia. Arrow upside is high and arrow down is low. So there is hyperkalemia. So friends, the key word to remember in RTA type 4 is, RTA type 4 is hyperkalemia. And one of the commonest cause of type 4 RTA is diabetes. DM is the commonest cause of type 4 RTA, right? So this is the summary. This is a golden line to remember. Only one, so entire RTA type 4 is squeezed into one word line. So the golden line to remember is number 1, golden line. RTA type 4, hyperkalemia and diabetes. I hope you understood. With this background, so now if you look into the question, we are understood. So answer is, what I said is A is the answer. DKA not possible, we discuss. And in these conditions, hypokalemia occurs. Here also usually hypokalemia occurs. So none of this is the possibility, because we are getting hyperkalemia. So we have comfortably ruled out. In this, hyperkalemia is possible, but this will never come to the OPD, it will go to the emergency. So just ruled out. So we are clear about this type 4 RTA. Now I like to talk basic concept about type 2 RTA and type 1 RTA also. The basic concept, type 2 again, same, dear nephron. And type 2 RTA, the site of disease is proximal RTA, proximal, PCT. Proximal convoluted tubule is this, PCT, proximal convoluted tubule. This is the site of disease. Now let's again, first we learn what happened normally. N for normal. Normally what happened, we all know that whatever this filtrate which come from the glomeruli, this composition is same as what is in the plasma, exact same is there, except this doesn't contain protein. In the filtrate, protein is not there, otherwise as far as electrolyte is concerned, all are same. And here what is absorbed? Sodium chloride, bicarbonate and sodium chloride, bicarbonate, and here protein and amino acid, A for amino acid, G for glucose, and potassium. Sodium chloride, bicarbonate and water. These are absorbed, all are at PCT. Sodium chloride, bicarbs, water. AA is amino acid, G for glucose and potassium. Now I have very simple question to ask to you, to the students. Okay, and because this lecture may be seen by some of the consultant, so these questions are only for the student, not for the consultant, not for senior person. Well, students, very simple question. Tell me what percentage of all these which are filtered in the kidney and they are reabsorbed at PCT, what percentage of these are absorbed? Quickly write down, I give you 20 seconds to think and answer. How much they are absorbed? Quickly write down the answer. Quickly, what percentage? Okay, yes, I hope you have written the answer. Well, it's a very simple question, and believe me, this is done wrong by 99%, so don't worry at all. Okay, all these are absorbed around 70%. it is 65 to 75, so average I'm taking 70. These three, they are absorbed almost 100%. 95 to 100%, so I'm writing 100%. This is a basic concept. So this happen normally. So definitely, if the PCT is not working properly, this is the PCT. If this is not functioning properly, so this compound will not be reabsorbed, definitely. So definitely, if they are not getting reabsorbed, everything will go out and filtered in the urine. But as a relevance of my talk, I'll focus on potassium. It is going out, definitely not getting reabsorbed. So this is the reason why hypokalemia will happen in this. It's getting wastage. Even bicarbonate is going out. So there will be bicarbonate urea. If bicarbonate is going out, so definitely it will lead to acidosis. Why? So why? Bicarb is a alkali. So if the alkali level goes down, so there will be increased acid. So loss of alkali is occurring, and that lead to acidosis. So friends, the summary to remember here is in type 2 RTA. Type 2 RTA, type 2. This is also known as proximal RTA. Why? Why proximal RTA? Because the site of disease is proximal convoluted tubule. So what we are getting is hypokalemia. Hypokalemia we are getting. And now a very good question. It is seen in which condition? This occurs in Fanconi syndrome. Fanconi syndrome. Okay. And which Fanconi syndrome? Wilson disease. Right. So friends, in this condition, all these are lost. In fact, everything is lost. The additional thing what I can write here is, other than these things, important things which are usually asked in the exam. Now, other important thing which happen in these two conditions is, write down, hypercalciuria. Okay, and additional two thing is it there lead to hypophosphatemia. Hypophosphatemia. Deliberately I have written them separately because I want to focus. This is the point where the student find difficulty. So let's discuss as a separate entity. Hypokalemia, why it happened, I agreed. Now hypercalciuria and hypophosphatemia. Point, and one more thing you should write here is, but no renal stones. No renal stones. So now I'll be discussing these two things, entities separately. Again we come back. So what happened in this condition? In case of RTA type 4, in type 2, we also know that here calcium is also absorbed. So as this is not functioning, PCT, this calcium will also go out, and the phosphate also goes out. Large amount of calcium and phosphate goes out. That's why there is hypercalciuria is there. And the phosphate is going out of the body. So in the serum, phosphate level will be reduced, hypophosphatemia, because calcium is going out, a large amount of calcium in the urine, and phosphate is going out. In the body there will be low phosphate level. But why it is so important to talk separately? Yes, so Large amount of calcium going out, and that will lead to what? Osteomalacia. Calcium going out, phosphate going out will lead to osteomalacia. But one thing, the most important line you don't have to forget, there is large amount of calcium going out, but still no renal stone. Why? What's the reason behind? It is so important. Universal question asked in the all exam. Here urinary citrate level. Urinary citrate level is normal. What the importance, this I'll be discussing in the next slide. But as of now, the golden line to remember is this. So this is summary. If you know this much, you can answer any question on RTA type 2. So this is a golden line number 2. Okay. So RTA, so-called proximal RTA, hypokalemia, seen in Fanconi syndrome, Wilson disease, which is a copper disorder, and we are getting hypercalciuria, but there is no renal stone, and hypophosphatemia, osteomalacia, and normal urinary citrate. Okay, so this is the type 2 RTA. Well, now we discuss type 1 RTA. This is also known as distal RTA. Why this is known as distal RTA? Here is the, again we go to basic concept. The basic concept goes like this. Nephron, and we know very well that we have a aldosterone which acts on the distal part of DCT and the collecting tubule. I mentioned in the type 4 also. And in type 4, the site of disease was same, DCT and collecting tubule. Here also, the site of disease is DCT and collecting tubule. Here, aldosterone level is normal. Point to be noted, in type 4, the level was reduced. So as this sodium aldosterone level is normal, then what will happen? It will be absorbed, normally it will absorb 2 sodium, and water will be absorbed as usual. It's normal, there's no problem in sodium reabsorption. But the problem is here, ideally one H ion should go out, and ideally one potassium should go out ideally. As per law of electrostat, 2 positive particles absorb and 2 should go out. Here the problem is this H ion doesn't go out. So defect lies in the H ion secretion in the DCT and collecting tubule. H ion is not going out, so H ion will remain in the body, and that lead to what? Excess of H ion in the body is acidosis. We just remember, the H ion is retaining in the body is acidosis, understood. But what about potassium? If this H ion is not going, 2 positive particles have come inside, body has to throw out 2 positive. So now body has to secrete 2 potassium. Double potassium will go out, that lead to what? Hypokalemia. So in the serum, in the blood, the calcium, potassium level will go down because excess of potassium is getting secreted. Not only that, because body has to secrete large amount of positive particle, so even calcium also goes out. Just to compensate this particular entity which is not going out, the body cannot secrete excess amount of potassium, because excess potassium will lead to arrhythmias. The body has to secrete calcium also. So there will be hypercalciuria also. So let us see what all we are going to get in type 1 RTA, type 1 so-called distal RTA. What we are getting is hypokalemia. And number 2, H ion is not going out in the urine. So normally urine pH is always acidic. It is below 5.5 normally, but here HI is not going out. The urine pH will be always more than 5.5. So what they say, there is defective acidification of the urine. There is hypercalciuria, the reason I told you. But here, renal stone formation is a feature. Renal stone formation is a feature. Remember, in the previous one, in the type 2, renal stone formation was not there. The reason being here, urinary citrate level is reduced. Low serum urinary citrate level. So citrate level is reduced, and that precipitates stone, and osteomalacia occur here also. Osteomalacia occur in this condition also. So friends, this is the summary of the entire RTA type 1. This is golden line to remember 3, right? So a quick recap of the whole RTA in just 20 seconds. So hallmark of type 4 RTA is hyperkalemia and diabetes, and aldosterone level is reduced. In type 2 RTA, proximal RTA, seen in Wilson disease and Fanconi syndrome, there is hypokalemia, there is hypercalciuria, but renal stone formation is not there. Osteomalacia is a feature. In type 1 RTA, distal RTA, hypokalemia, but urine pH is more than 5.5. Hypercalciuria, but renal stone formation is there because the urinary citrate level is reduced, and osteomalacia occur here also. That's all. If you remember these 3 boxes, golden line, okay, or golden boxes, whatever you can say, you can answer any question on these RTA. With this background, so golden line I have written separately also. Anybody who could not copy, they can copy it. Golden line in the whole one box. In hyperkalemia, in type 2 hypokalemia, Fanconi, hypophosphatemia, hypercalciuria, renal stone are not. Normal urinary citrate, type 1 hypokalemia, urine pH more than 5.5, hypercalciuria, renal stone, and low urinary citrate. So everything gathered here in just compact way. With this background, now we go to question number 2. We are getting a 23-year-old man, recurrent attack of hepatitis, jaundice, bony pains, muscle weakness, polyuria, and polydipsia. Okay, slit lamp examination shows greenish brown discoloration in the cornea. What is this? Now the question is very easy. We are getting a patient of recurrent jaundice. Now look into this. Recurrent jaundice is the key word to be noted. And we are on slit lamp examination, you are getting a brownish discoloration of the cornea. Well, this is a clear cut. If you basic concept, if you know this word, he is talking about Wilson disease. We know where Wilson disease is a disorder of copper metabolism. And in this, we have patient has a recurrent jaundice and they have a greenish brown discoloration in the cornea. Okay, and we know in Wilson disease we have type 2 RTA. Type 2 RTA, in type 2 RTA, what happened? There is hypophosphatemia occurs. Is there a hypercalcemia in type 2? No way. Hypokalemia occurs. Now you can answer very comfortably because you know the basic. Is there hyperkalemia? No, there is hypokalemia and no hypercalcemia because lot of calcium going out. So in this is talking about in the blood or serum. No way. Potassium going out, leaking in the kidney, in the blood level goes down. Same calcium level goes down in the blood. Increased bicarbonate. No, bicarbonate getting reduced. It is also getting filtered. Metabolic alkalosis. No, there is metabolic acidosis is occurring. Yes, hypophosphatemia, because phosphate is being lost. So we have ruled out other, and now we are very clear about hypophosphatemia occurs. Okay, so in this question, jaundice and ring seen in slit, Wilson disease, type 2 RTA. Now a question only for the student to answer. Tell me the name of the ring that we see in Wilson disease in the eye. It's a very simple question. By slit lamp examination, you get only 10 seconds to write the answer. 10 seconds. Quickly write down. Well, I'm sure the answer is Wilson disease. A Wilson disease, you see KF ring. So we get KF ring, which is virtually is very strongly suggestive of Wilson disease. Okay, now the things are easy for you to answer. Okay, so we get a 3-year-old child and generalized weakness and dehydration, a long list of admission. Oh, because the child is not able to thrive. Repeatedly he is getting hospitalized, and they they have given diagnosis also of Fanconi disease. Okay, well, you are lucky that you are getting answer. But now he's smart. What the pathogenesis of this condition? What are asking, what is the actual site of problem and what is happening? Well, the answer is global resorptive defect in PCT. Global means PCT, we know it's a site of disease PCT, but the word he uses global. Global means everything is being lost. The way I told you, the PCT is not working. There is amino acid urea, glucose urea, potassium also lost, calcium also lost. So we use the global resorptive defect is there. Let's look into other options also. Decreased activity of sodium in DCT. No, there's nothing. It is not a disease of DCT at all. So we don't need to read this thing. Increased sensitivity of aldosterone. No way. Aldosterone is in DCT. Nothing to do with aldosterone. What about increased activity of epithelial sodium channel in DCT? It's not a disease of DCT. We rule out. And other thing, defect causing reduction in sodium potassium co-transport. This is again not seen. This is seen in ascending loop of Henle. So one thing is very clear. Other option, they are talking about DCT, not DCT, not, and again aldosterone not, and this sodium transport. This happen in the ascending loop of Henle. This happen in the ascending loop of Henle. So the best answer, we rule out technique only. Answer is global resorption in. So he's talking of Fanconi syndrome is PCT. Let's look into question number 4. We have a 35-year-old woman, Osteomalacia, renal calculi are there. Twice in the past, there is hypokalemia and hyperchloremic acidosis. Okay. What's the most likely finding in this urine? Most likely finding. So if you analyze this question, we have a lady, hypokalemia is there, and there is acidosis, osteomalacia, and renal calculi are there. It means he's talking about type 1 RTA, right? So in type 1 RTA, urinary citrate level are reduced. That's a reason why calculi are made. Point to be reminded again that in case of type 2 RTA also, there was hypercalciuria. There was hypercalciuria. But still the stone formation was not there because urinary citrate level was normal. Okay, urinary citrate was normal, and in fact it is the citrate, low citrate level which precipitate the stone formation. Decreased urinary calcium level, no way. It is hypercalciuria occurs in this. So this is not the answer. Decreased urinary potassium level, no. It is excess of potassium is being lost. So this is not the answer. I hope you remember. HIN is not going, potassium going extra. So there will be increased potassium. Increase urinary ammonium level, no, because HIN is not coming in the urine. Normally what happened, it is the in the urine we have a ammonia that combined with HIN to make ammonium molecule. But HIN is not coming, so ammonium will be reduced. And finally, urine pH less than 5.3, no way, it is more than 5.5. So by rule out technique also we have found the best answer. Of course, this is the answer we knew very well. We went for this answer, but at the same time, it is our duty to look into all the options, and we find all other options they do not fit. So we are very comfortable in answering B Bombay as the answer. So the keyword are in this question: hypokalemia, osteomalacia, renal calculi, NAGMA. NAGMA is normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis. Okay, reduced urinary citrate, this all RTA type 1. Clear cut. Okay. So friends, if now I give a summary of RTA. We finished RTA. And of course, one more thing I like to add before I go, this type 1 RTA, this is seen in condition like Sjogren syndrome. And we also see in via amphotericin therapy. Amphotericin therapy, there is an antifungal drug that can also lead to RTA type 1. So to conclude the whole show, entire RTA only in few seconds. So summary, RTA type 4. Okay, yes students, you answer. Now you answer the questions. A quick recap. In type 4 RTA, what happened to potassium level? Increase. Next question, what is the most common cause of RTA type 4? Diabetes. Next, in case of type 2 RTA, what is the site of disease? PCT. Okay, what's the important syndrome which occurs in this condition? Fanconi syndrome. Now what happened in this? What happened to potassium level in the urine? Excess potassium goes out, and that lead to hypokalemia in the blood. What happened to bicarbonate level in the urine? Excess bicarb goes out, that lead to metabolic acidosis. What happened to calcium phosphate in the urine? So calcium, phosphate, glucose, amino acid, everything goes out. So that lead to hypercalciuria and low serum phosphate in the blood. Phosphate level goes reduced. Does renal stone formation occur in RTA type 2? No way, because urinary citrate level is normal. Type 1 RTA, also known as, yes, distal RT. What happened to potassium? Goes out. What happened to aldosterone level? In type 1, normal. And remember, in type 4 RTA, aldosterone level was reduced. Now in this, what happened to calcium in the urine? Hypercalciuria. What happened to renal stone? Yes, formation occur. And urinary pH level, urine pH is more than 5.5. And finally, renal stone formation occurs. Why? Because the urinary citrate level is reduced. That's all. Your every question will come from this summary only. Okay. With this background, we move on to another difficult topic, so-called renal tubular acidosis. acid-base disturbance. Again, very confusing topic, but don't worry, I'll just make the revise only in 10 seconds. Okay. So before we discuss, let's see the first question in this case. Or the question is this. We have 57-year-old men. 4 days shortness of breath. There is 25 years of history of smoking. Oh, definitely if he'll smoke for 25 years, he's bound to have some COPD, emphysema is there. Little bit of crepitations are there. And if you look into the blood gas analysis, pH is 7.23, O2 is reduced, CO2 is normal, but bicarb is reduced. Okay, bicarb is reduced. If you look into this, which is the best answer? Best answer is primary metabolic acidosis. Why? The keywords pH is 7.23, CO2 is 40 and the serum bicarb is 16. But this is not enough for us to understand. So friends, why this the answer, why not others? This you will never understand unless you know the basic concept. Let's learn about basic concept about the acid-base disturbance. This is very essential to talk from very, very basic. So let's talk about normal values. Normal value of pH is 7.36, normal blood pH. Serum pH is 7.36 to 7.44. Average we take as 7.40 for easy calculations. I'm taking 7.40. Normal serum bicarbonate. So in the serum bicarbonate is 22 to 28 milliequivalent per liter or millimole per liter, and the average I am taking as 24. And normally partial pressure of CO2 in the blood is 40 to 45 millimeter of mercury. Now I have a question for the students. So what should I take? Should I take 40? Should I take 42.5? Or should I take 45, or I can take any? I give you 20 seconds to think and answer. What should I take? Very simple. Quickly write down the answer. What should be the answer? 40, 42.5, 45, or any? I can take any. That doesn't matter. Well, the right answer is 40. Why this the answer? Why not others? Again, basic concept. This 40 we see in arterial blood. And this we see in the venous blood, 45 in the venous blood. So whenever we do the acid-base analysis, we always take arterial sample. We never take venous sample. So when we are taking arterial, so there will be 40. So there is no point of these. So don't commit this mistake. We always take arterial sample. So now if I have to tell you what all you have to remember 7.40, 24 and 40. Only 3 words to know the basic about normal values. But here is a big confusion. What confusion? There is no confusion. Yes, there is a confusion, and that's why people don't understand the basic concept about acid base. Let me discuss that basic also. So what I said right now is normal value is 7.40 is the average pH which I discussed. Anything above 7.40 is alkali. Anything below 7.40 is acidic. But with a confusion, Yes, confusion is there. Because in our school days, we were taught in our physics and chemistry classes, the normal pH is 7. Anything above 7 is alkali. Anything below 7 is acidic. This is what is given in school physics and chemistry. This is in the medical sciences. So, as far as school physics chemistry is concerned, 7.21 is alkali. But as for medical sciences, 7.21 is acidic. This confusion should be removed. So friends, again repeating second time. Normal pH is 7.36 to 7.44, average 7.40. In medical sciences, in the blood, so anything above 7.40 will be alkali and anything below 7.40 will be acidic. They are the basic concepts, right? With this background, we still talk more about basic concept, yet not finish. If you look into this bicarbonate, we all know this is a alkali. This we know. Alkali remain alkaline. It doesn't change into acidic, definitely. And is mainly being controlled by kidneys. And we have a CO2. We all know CO2 is a acidic. This is a acidic gas. Everybody knows about it. Is a acidic and being controlled by the lungs. It's too simple, right? So bicarb is alkali controlled by kidney, CO2 is acid controlled by the lungs. Yeah. With this background of basic concept, more basic concept. So whenever we have a acid-base disturbance, primarily bicarb or CO2 level will change. Definitely. So now if any problem occurs due to bicarbonate, any problem we call as metabolic, and any problem which occurs due to CO2 we call as respiratory. So friends, we learn something more, that any disturbance in the body due to bicarb is metabolic, any disturbance of CO2 is alkaline. Understood. Now we still got to know more basic concept. The more basic concept is, look at me, this is acid, alkali. We have an acid in the body, we have an alkali in the body. Gain of acidosis is gain of acidosis. So what I want to convey, what are the basic concept or what are the mechanism by acidosis and alkalosis occur in the body? Gain of acidosis, loss of alkali is also acidosis. Gain acidosis, loss alkali, acidosis. Gain of alkali, alkalosis, loss of acid, alkalosis. It means acidosis can occur due to gain acid or loss alkali. Alkalosis can occur due to gain alkali or loss acid. These are the basic concepts. With this background, we move on to basic concept, how in the body acidosis and alkalosis occur. Okay, the basic concept is like this. How acidosis and alkalosis occur in our body. So suppose there is increased CO2. So what we learned just now, any disturbance of CO2 is respiratory. So it has to be respiratory. Now CO2 is an acid, gain of acid lead to acidosis we just learned. So in case CO2 will be respiratory acidosis. Reduce CO2. So definitely any problem of CO2 is respiratory, we learned right now. And loss of acid lead to what? Alkalosis. We have a increased bicarbonate. What we learned just now. Any problem of bicarb is metabolic. And we know bicarb is an alkali. Gain of alkali lead to what? Alkalosis. Alkalosis. And if the bicarb is reduced, so any problem of bicarb is metabolic, and loss of alkali lead to acidosis. Friends, this is the summary that you cannot, golden line number 4. It's the golden line number 4. Okay, this summary, right? With this background, we move further. So we learned about the basic concept. Now I'm going to discuss about the compensation. Compensation. So again we learn what is the meaning of compensation. The basic concept. BC stands for basic concept. The basic concept goes like this. Just now we learned normal pH is between 7.36 to 7.44, and for easy calculation I have taken average as 7.40. So this is the normal range of the pH. So we have a comfortable area sorry, in which the pH moves perfectly all right. But there are so many diseases where the pH is disturbed. Okay, pH is disturbed, so it can go down. This is maybe 7.0, this is 7.80. So pH can go either way due to so many diseases. So that will lead to disturb pH in any condition, in some diseases. But by and large, in the body can survive up to 7. If it goes below 7, usually life is not compatible. Similarly, if the pH goes above 7.80 or 7.70 or 7.80, life is not compatible. The patient dies. So you can say this, the yellow color is the area where the life is very comfortable, and either way is life is disturbed. Or I can say with this what we can say, that if it is in the range, green color I am showing here, the life is possible, but body need to bring back the pH to normal. Body, so body has made certain mechanism by which pH is brought back to normal. So whenever the pH get disturbed, here body will try to bring the pH to normal, or here body will bring the pH to normal range, and this process of bringing back the pH to normal is so called compensation. But why and how this compensation occurs, let us see. Let's take an example. Once we learn the basic, then things will be very, very easy for you. So let's take a case of pH is 7.21. What is this? Acidic. We know anything below 7.40 is acidic. Bicarbonate, this is 10. Low bicarb is metabolic acidosis, that we know very well. PaCO2 is 40, is normal. So what we call this, we call as metabolic acidosis. Okay, this is a case of metabolic acidosis, and we also call as uncompensated. Uncompensated metabolic acidosis. Why? I'm going to discuss in a minute only. So this is a scenario we are very sure that it's a case of metabolic acidosis, because problem lies in the bicarb level. So let us see what happened in bicarb compensation. Bicarb is controlled by kidneys, that we know, and CO2 is by the lungs, that we know. This is the scenario. Well, this is by kidney and lungs. Lungs and kidneys are very good friends. Okay, lungs gives a call to his friend kidney. Okay, and they are talking to each other on mobile phone. Sorry. Kidney gives a phone call to lungs. Hello lungs, how are you? Oh, lungs says, oh, I'm fine, comfortable, sitting at home, enjoying a cup of tea and listening to Dr. Bhatia. Lung says, in a very cheerful way. Well, he's listening to Dr. Bhatia, he has to be cheerful. Anyway, now the lung says to kidney, and my friend kidney, how are you? Kidney says, oh, very bad, very bad. Lung says, what happened? Kidney says, metabolic acidosis, pH 7.21, bicarb 10. Kidney is weeping, tears in the eyes, in the kidney. Lung says, don't worry, my friend, मैं हूं ना. I'm there to help you, don't worry. A friend in need is friend indeed. Yes, you are right. So now kidney want to help his friend, lungs want to help kidney. What lungs has? Lungs has acid. Immediately lungs will start. We all know normal respiratory rate is about 12 to 16 per minute. Is the normal respiratory rate. Now what lungs will do? Look at me now. What is doing? Increase in the respiratory rate. And one more thing you noted down. Look at me once again. Increase depth of breathing. You will never forget. Increase rate of breathing, increase depth of breathing. Why the kidney is doing it? The kidney is trying to wash out CO2. After some time, the CO2 becomes 30. Bicarb 14 and 7.30. And finally, it becomes 26, 16 and 7.40. Okay. Although there is a definite formula is there, I'm going to discuss little later on. But as of now, just learn that finally the pH has been brought to normal. Brought to normal is a compensated, and of course CO2 has gone down and bicarb has gone to increase. But look into the pH, this is compensated. Let's take one more question. We have a pH of 7.60. What is this? Alkalosis. Anything above 7.40 is alkalosis. This is the 35. Increased bicarb, metabolic alkalosis, CO2 is normal. So now we can vary. Now things are easy. Is a case of metabolic alkalosis. And definitely it is not compensated. Same story. Kidney is in trouble. Lungs will help. Now what lungs? It will reverse. It will have a reduced rate of breathing. And it will have a shallow breathing. Shallow breathing, lung will have very slow breathing. So idea is to keep the CO2, let CO2 should not go out. So it's exactly reverse. So here we have a shallow breathing. Here we have an increased breathing. This is known as small breathing. Previous one, where it was rapid rate of breathing was small, and here it is a shallow breathing. Shallow breathing or so-called slow breathing. Ultimate aim is to retain the CO2. So after some time it become 46, it become 31, 7.50. After some time this become 50, this become 27, 7.40. It has been compensated fully. Let's talk about one more case. One more case, we have a pH of 7.22. It is acidic beyond doubt. Bicarb is 24, it is normal, and CO2 is 70. So now increase CO2. This is a case of respiratory acidosis. CO2 high, pH is in the acidic range, and CO2 bicarb is normal. So it's a case of acute respiratory acidosis. Now these lungs are in trouble. Kidney is the friend. Okay, what the kidney? Kidney has alkali. Body wants alkali because acid level is very high. So how do you think kidney will compensate? They will try to retain bicarb. So in that way, this become CO2 will go down 7.30. So kidney is trying to compensate by trying to retain bicarbonate because body needs bicarb. Is severe acidosis is there, and after some time, okay, so it will become 32. This becomes 60 and 7.40. It has been fully compensated. And finally, easy to do 7.60, 24 and 10. Do I need to tell you the case of what? Acute respiratory alkalosis. Why? Why alkalosis? This pH is 7.60 and bicarb is 10. Low bicarb is respiratory alkalosis. Now what kidney will do? Kidney will try to wash out CO2. This becomes 20, 12, 7.50. This becomes 16 and 14 and 7.40. Fully compensated. So now you learn the basic concept. But now again we come back. So what I told you, the disturbance can occur in either way. Either way disturbance can occur, and finally the body has a mechanism by which pH has been brought to the normal yellow range is compensation. This is just to explain to you what the meaning of actual compensation, right? With this background, now we move on to, in fact, there is an actual formula is there, and that is so called, this is not known to most of students. We have a Winter's formula, okay? We have a Winter formula. By this we tend to calculate how much CO2 should be there to compensate. Okay, now if I give you the formula first, then I'll give you how to calculate, then things will become very, very easy for you. So friend, we take bicarbonate level, we multiply by 1.5. We take serum bicarbonate, of course. When I say bicarb means serum bicarbonate, multiply by 1.5. After that, plus 8 plus minus 2. Suppose the bicarb level is 10. Then how much CO2 should be there to compensate? 1.5 plus 8 plus minus 2. This becomes 15 plus 8 plus minus 2. This become 23 plus minus 2. This become 21 to 25. So if bicarb is 10, then after compensation if the CO2 is in the range of 21 to 25, that means it has been adequately compensated. Okay, right? Understood? So again, look into this. Bicarb is 10. This is bicarbonate. And the CO2 should be in the range of 21 to 25. So this is the bicarbonate, and the CO2 should be in the range of 21 to 25. Got it? 21 to 25. Here lies the most confusing point, not known to. Well, this is there. As per Winter formula, if our CO2 is in the range of 21 to 25, adequately compensated. Suppose the CO2 value is 30. What do you think? What do you think it should be? Again, we analyze. See, if you go by PaCO2 30, normal level is 40. Yes, we know very well. Normal CO2 is 40, and if CO2 is below 40, then we call as respiratory alkalosis. Definitely, we know the basic concept. Low CO2 is respiratory alkalosis. Here it is 30. Should we call it to respiratory alkalosis? Ideally, yes. But in actual, no. What is really confusing? At one place, actually, yes, and okay, and we know also yes. This is the point where student gets stuck up. Now, so whenever you get any question, you calculate as per Winter formula. If it is occurring in the range, like in our question 10, it was between 21 to 25. Suppose the CO2 of this was 23. So we will say it is adequately compensated. But if the CO2 is 30, which is not in the range, so we still call it to be case of respiratory acidosis. You mean to say, sir, if we get in the question, bicarb is 10, CO2 is 30, so we will be calling not as a respiratory alkalosis, we'll call as respiratory acidosis. Point to be noted. So it should be in the normal range. So despite having high CO2, we still call as respiratory acidosis, not alkalosis. So let's calculate. Let's give some more example. Bicarb, CO2, 10, we want CO2 in the normal range of 21 to 25. We just calculate it as per Winter formula. Suppose this is 14. So 14, if you calculate, 14 multiplied by 1.5 plus 8 plus minus 2, this becomes 21 plus 8 plus minus 2. This is 29 plus minus 2. So this comes out to be 27 to 31. So this is 27 to 31. So if the CO2 is in this range, we call as adequately compensated. But if they are above that, suppose in this case you get a CO2 is 33, so we still call as respiratory acidosis. Right? Understood? So friend, the golden line to remember is Winter formula. That is bicarbonate, just a minute, is some problem. Just wait, there's some problem in the system. Just a minute, huh? Wait. Sorry for the interruption. There was some mechanical technical problem. Sorry for the inconvenience. So golden line to remember is winter formula. Winter formula. We calculate bicarbonate multiply by 1.5 plus 8 plus minus 2. If you know this formula, you can solve any question on the entire acid-base disturbance. So if I have to give you, I promise you that I will make you revise the entire acid base only in 10 seconds. So you have to remember this golden formula or golden line number, I think 5. So the previous box was increase CO2 is respiratory acidosis, decrease CO2 is respiratory alkalosis, increase bicarb metabolic alkalosis, reduce bicarb metabolic acidosis. And the whole summary of acid-base disturbance is winter formula bicarb 1 multiplied by 1.5 plus 8 plus minus 2. This is a range. If it is occurring in the range, we call as adequately compensated. If it is still on the higher side, we call as respiratory acidosis. And if it goes below this, if it go below that, one more thing, this is the, suppose this is the compensative CO2 what we want in the normal range. This, if it is come in the normal range, as per winter formula, we say adequately compensated. If it is on the higher side, it is respiratory acidosis. Lower side, it is respiratory alkalosis. But by and large, in all the exam, they will be talking about this. They never talk about this. Point to be noted that is the CO2 is maybe low, but it's still not compensated, is respiratory acidosis. With this background, we come back to our question, what we were talking about. So this is simple. We have a pH of 7.23 is acidosis. CO2 is normal, and this is bicarb is 16. So it's a primary metabolic acidosis. Let's look into other option. Is it normal acid base? No way. Low pH cannot be normal. Is it respiratory acidosis? No way, because CO2 is normal, so this cannot be. Is it a mixed metabolic acidosis and respiratory acidosis? No way. CO2 is normal, so this is not a respiratory acidosis. And finally, metabolic acidosis and metabolic respiratory alkalosis, no way. CO2 is normal, so this cannot be. Now, again, I like to tell you certain more basic concept. Still more basic concept based on the what we learned. We learned based on the so-called compensation. What is this? What is this? Little bit more. Look into this. Look into this. pH is normal. Rather, I can tell you one more thing. You leave aside the pH. Can we talk something without pH? Bicarb is 16, metabolic acidosis. CO2 is 26, is what? It is respiratory alkalosis. Look into this. This is 27. Bicarb is 27 in the normal range. Or if I say it's like, or this is 50. Let's say this is 30 and 50. This is what? Bicarb is metabolic alkalosis, and this is respiratory acidosis. So in one patient, because of compensation, due to compensation, there can be mixed picture also. About this, I'm going to discuss in the coming lectures, in the coming questions. Right now, we learn that there can be, depending on, of course, ultimately you have to use winter formula. So we use winter formula. Winter formula, like in this question, we have it 10 is the bicarb and 31 is the CO2. So we call as, is a case of mixed metabolic acidosis and respiratory acidosis. Why? It is in the range of 31. So that's why there can be a mixed picture also. But this happens only after compensation. Use winter formula, your question will be solved. With this, now let's go to the question number 2. We are getting one 23-year-old male, type 1 diabetes. He's brought to emergency with confusion and he has missed several doses of insulin. Okay, and his breath has a mild fruity odor, which the most likely diagnosis. If you look into the question again, he is a case of 23-year-old type 1 diabetes. Keyword is type 1. He has brought with confusion and he has missed several doses of insulin and mild fruity disorder. So examiner has given you enough indication and that we are dealing with diabetes ketoacidosis. What is the point? He is a case of type 1 diabetes. DKA is more common in type 1 diabetes. Confusion, DKA confusion is very common. And what can precipitate? He has missed several doses of insulin. And fruity disorder is what classically we see in DKA. He never mentioned directly DKA, but he gave you enough DKA. Okay. So in DKA, it's a type of acidosis. So what happened? What happened? pH will go down. Why? Why pH will go down? It's acidosis. CO2 level will, like bicarbonate level will go down. Yes, it's a case of metabolic acidosis. It's a case of metabolic acidosis. We have learned that in these cases, this bicarb level is go down. And due to this acidosis, the phosphate level goes high. DKA is a very, very important cause of hyperphosphatemia. serum phosphate level increases in decay. Point to be noted that in case of type 2 RTA, the serum phosphate level went down because there was loss of biphosphate in the urine. Okay. So classically in this case, we have a DKA, which is the form of metabolic acidosis, decreased pH, decreased bicarb, and CO2 will also like to go down. Why? Because CO2 will like to go down because of compensation. Okay. So CO2 level will go down, but phosphate level will go high because in hyperphosphatemia is a feature of decay. So what about these options? If the pH will go high in DKA acidosis, no way, ruled out. These are possible. These two are possible. Bicarb will go down, yes, but phosphate level is increased in DKA. And in this case, pH low, bicarb high, no way. It's a metabolic acidosis. The bicarb level will go down and phosphate level increase. This is true, but this is not true. So these are out. This is out. This is out. Finally, option D remains the best. So this you can answer, but your basic concepts are very, very strong. So let's talk about question number 3. 33-year-old man, type 1 diabetes, 2-day history of vomiting, pain in abdomen, temperature is little high, pulse is increased, respiratory rate is increased, bicarb reduce, potassium in the normal range, and CO2, if glucose is 460 milligram percent, and if you convert into millimole per liter, how we convert? We convert by dividing milligram percent by 18. Okay, so that we convert into millimole per liter. So it should be somewhere around. If you divide, let us I get 20, somewhere around 25, I suppose. Anyway, idea is, the formula is, if you want to convert milligram into millimole, you divide by 18. So somewhere around 25 millimole per liter, right, sir? So we are getting CO2 is 29. 29 is there. Let us see what is happening. What's the reason? What is the best reason for that? Okay. We calculate bicarb is 14, and now you do the winter formula and tell me. I give you 20 seconds to do, and let me know, if you use winter formula, what should be the CO2 in this. I give you 20 minutes, 20 seconds, not 20 minutes. Quickly do it. Winter formula. So 14 divided by 1.5 plus 8 plus minus 2. This is 21 plus 8 plus minus 2. So this is 29 plus minus 2, 27 to 31. So this comes out to be 27 to 31, and our is 29. It is very much fully metabolic control. This is the answer. Is it normal? No way, it's not normal. Is a metabolic acidosis without compensation? No. It has come in the normal range. It is fully compensated. This is not the answer. Metabolic alkalosis, no way, is no way alkalosis. Why? No way, bicarb is reduced. So this should be metabolic acidosis. So this is not the answer. Respiratory acidosis with compensation, the CO2 level is reduced. So this cannot be the answer. So this is the best answer by knowing the basic concept of Winter formula and also by rule out technique. So friends, ultimately in whole acid base you have to remember the Winter formula. Summary, the entire acid base quiz in only one line. Winter formula is that bicarbonate multiplied by 1.5 plus 8 plus minus 2 is the CO2 value that we get it. If it is come in the normal range, is compensated. If not, it is not compensated. This is the summary. Okay, I hope things are very, very simplified. Now I have now let's talk of anion gap. We have a question, interpret the data, CO2 is 40, O2 90, sodium, potassium, bicarbonate, chloride. Calculate the anion gap and what condition you can see. The answer is hyperparathyroid. Why this the answer, why not others? This you will never understand unless we know the basic concept about Winter's formula. Okay. So basic concept about anion gap. How we calculate anion gap? Sodium minus chloride plus bicarbonate. But before I proceed further, let me tell you one more confusion. I have written sodium minus chloride plus bicarbonate, but in some of the books they have written sodium plus potassium minus chloride bicarbonate. This is also written in some of the books, but majority of the books they talk about this formula. Okay, or in the exam also, whichever you see, they may go by this. If you read Nelson pediatric book, they say this can be done by this way also, and this can be done by this way also. This one book is Nelson. Anyway, in Harrison and Oxford book, they go by this formula. So I'm going by this formula. Why it's my duty to tell you what way some confusion occurs. Different books, they do mention little bit different thing. It's my duty to clarify your doubts. So let's go by this. So we are getting, maybe sodium is 135. Chloride is 104. Bicarb is 24, average we have taken. Their minus particle 135 minus 128 plus 7. As per this formula, we are getting 7 extra positive particles. But we know very well, as per law of electrostat, positive and negative are equal everywhere in this universe. It means there are certain extra negative particles which are there, which we have not taken into consideration. So these negative particles, yes, phosphate, albumin, sulfate, lactate, all these are negative particles, so which are there. Okay, so and that's why the anion gap is there. So these we have not measured, we have not taken into consideration. So now if I have to give you a definition of anion gap, what's the definition of anion gap? It is the measurement of unmeasured anions. Unmeasured anions means sulfate, phosphate, lactate, which we have not taken into consideration. So this is the anion gap. Agreed? Yeah. So we learned the basic what the anion gap is. So let's talk about. We have a one patient whose sodium is 135, his chloride is 104, but his bicarb is 14. Now bicarb 14 means what? It's a low bicarb. It's a case of what? Metabolic acidosis. So now if you calculate the anion gap, this becomes 17. Normal range of anion gap, normal range is about 6 to 12. 6 to 12 is the normal anion gap, right? 6 to 12. Again, some of the books even have given 8 to 12 also. Some have given 8 to 14 also. So some variation is there, but by and large 6 to 12 is the general I'm talking about. Okay, it's again essential to tell you about the variation in the book, but in the usual exam they do give the range what the way examiner want. If they don't give you 6 to 12 or 8 to 12 is the best answer. Yeah, we understood. So here we are getting 17. Definitely it is more than normal. So we will call this 17 as an increase anion gap. So here we are getting increase anion gap. Why? Because of metabolic acidosis. Agreed? Now suppose we got one patient whose sodium is 135, his bicarb is 14. 14 means metabolic acidosis. But I want his anion gap to be normal 7. Is it possible to have a metabolic acidosis and normal anion gap? Is it possible? Yes, if chloride become 114. So here we are getting a normal anion gap, but at what cost? 114. So this entity we also call as metabolic acidosis with normal anion gap, and this entity was metabolic acidosis with increased anion gap. So this entity is metabolic acidosis with increased anion gap. This is metabolic acidosis with normal anion gap, also known as hyperchloremic metabolic acidosis. Why hyperchloremic? Because the chloride level is more than the normal. So there are two names, whether metabolic acidosis with normal anion gap or hyperchloremic metabolic acidosis. It's just to tell you how the basic concept is. With this background, now what he's going to ask you in the exam is this table which I'm going to give you in this, the golden line to remember, and whichever exam you write in the world, you will be getting one question from this table. I'm leaking the paper to you, but in a very honest way. So let's talk about golden line to remember. Write down the causes of metabolic acidosis. The first is increase anion gap. Arrow upward means increase. AG stand for anion gap. Here, A, certain diseases like diabetes, ketoacidosis. In the previous question, we did talk about like DK, metabolic acidosis, DK. This may occur in chronic renal failure. It occurs in lactic acidosis. It may occur in prolonged starvation. Now, this can happen in certain poisoning also. Certain poisoning include methanol poisoning, this important, make a circle. Salicylate poisoning, ethylene glycol poisoning, ethylene glycol poisoning, right? Then we talk about normal anion gap. That means metabolic acidosis with normal anion gap. This we see in renal tubular acidosis. We read in detail 1, 2 and 4 RTA. In all these, there is a hyperchloremic metabolic acidosis. It may also occur in acute pancreatitis. Okay, it may also occur in ureterosigmoid. In certain bladder cancer, ureter is transferred into sigmoid colon. So now the urine will go out of the sigmoid colon when we remove the bladder. So then this is so-called ureterosigmoidotomy. You are implanting ureter into the sigmoid of the large intestine. And diarrhea. In diarrhea also, we have a normal anion gap. Now one thing very interesting, there are few conditions where the anion gap may be even less than normal. Less than normal. Less than normal was 6 to 12. So if the anion gap is 2, 3, 4, 5, and this we call less than normal, and this we see in multiple myeloma. MM is multiple myeloma and hyperparathyroid. Hyperparathyroid. Friends, this is the golden line to remember. Make a box. This the golden lines to remember is number 6. This is what you got to remember. Now let us see, I hope you are written. Let's see, go back to our question. So in this case, now all the students, you calculate the anion gap. Quickly, the anion gap is sodium, how much? 135. How much is chloride? 110. Bicarb is 23. So what we are getting is 135 minus 133. Oh, anion gap is 2 only. It is less than normal. So less than normal. Do we see in RTA? RTA we see normal gap, rule out. Lactic acidosis we get increase anion gap, rule out. Salicylate poisoning, increase gap, rule out. Chronic renal failure, increase, rule out, rule out. Hyperparathyroid? Yes, in hyperparathyroid we get normal. So we are clearly, directly also we are clear, and we have ruled out other option also. So now we are very sure that we are dealing with hyperparathyroid. Look into this beautiful question. Lovely question is this. We are getting a 73-year-old man. He is hypothermic. Hypothermia classically occurs and unconscious also. Of course, there are patient is exposed to severe cold that can lead to hypothermia. But otherwise, in a routine patient, look, he collapsed in the kitchen. So we presume he was at home, so he was not exposed to severe cold. And he is known to diabetic. What is talking about? So in which condition hypothermia can occur? it can occur in septicemia. Septicemia, severe infection is there. If the temperature can be very, very high. The patient can have very high fever. But sometime in septicemia, temperature may be very low. Patient may be hypothermic also. Hypothermia. And we also know very well in diabetic patients, the septic infections are very common. And that can lead to altered sensorium. That's why he was fall. His sodium is 139, potassium is 4.5, chloride 97, and glucose is 5.6 millimole per liter, and bicarb is 18. Oh, let's analyze. Bicarb is 18. One thing is very clear, that we are dealing with metabolic acidosis. Agreed? Yes. Now his glucose is 5.6 millimole per liter. Okay, let's calculate. If you want to convert into milligram percent, what you do? You will multiply by 18. So milligram to millimole you divide by 18, and millimole to milligram you multiply by 18. So this comes out to be 18, somewhere around 89, if I'm not wrong. My mathematics is not so good. Somewhere around 89, okay, or 90 के आसपास. Okay, normal range. It's quite normal. 18, 90 is normal. So let's look. So what we got is normal sugar. Sugar is glucose level is normal. Bicarb is reduced. Metabolic acidosis is there, and he has hypothermia. So answer this question is lactic acidosis. Okay, lactic acidosis is there. Well, if you calculate the anion gap, let's calculate anion gap. Sodium minus chloride. How much chloride? 97. Chloride 97. And bicarb is 18. Yes. So the anion gap is 139 minus, this comes out to be 115. Yes. So 11542. The anion gap is 24. It is increase. Definitely the normal range is 6 to 12. So we are getting increased anion gap. So this is ruled out. This ruled out because in these two conditions, the anion gap is normal, ruled out. Now these three conditions, we can have increased anion gap, agreed. But what about hypothermia? Hypothermia occurring in septicemia. And one of the classical acid-base disturbance in septicemia is lactic acidosis. In septicemia. And why we are thinking about the hypothermia? So out of these, this is the better answer. What about DKA? Sugar is normal level. It is somewhere around 89. In 89 sugar, DKA does not happen. And moreover, alcoholic acidosis, there is nothing mentioned about anything about alcohol or whatever it may be. There is nothing like. Moreover, by rule out technique and by this also, we are quite sure that we are dealing with lactic acidosis where we have increased anion gap is there. Okay. So when the anion gap is increased, we call as HAGMA. HAGMA stands for high anion gap metabolic acidosis. When the anion gap is normal, then we use the term as NAGMA, normal anion gap metabolic acidosis. Hugma and nugma are the two terms that we frequently use in most of the books. So in our case, hugma is there, decreased bicarbonate, anion gap 24 hugma, hypothermia, septic shock, lactic acidosis, the summary that we discuss. Look into this question. 3. 30-year-old man, pain, hematuria, potassium is 3, pH 7.3, anion gap is 11. Oh, he's normal anion gap. Hypercalciuria, ureteric calculi. What is talking about? Where do you get all these findings? So in DKA, first of all, anion gap is increased. Here, anion gap normal ruled out, not possible. Lactic acidosis, anion gap is increased, ruled out. Our is normal anion gap. Salicylate poisoning, anion gap is increased, ruled out. Uremic acidosis, that means chronic renal failure, is ruled out. It's all increased anion gap. By rule out technique also, we have known that we are dealing with normal anion gap, and the only normal anion gap we see in renal tubular acidosis, and that we know we have a type 1, type 2 and type 4. Now I give you another 20 seconds. Tell me in this question which type of RT is there. Quickly do in 20 seconds. Well, the answer is what? Type 1 RT. He has hypercalciuria and ureteric calculi. Remember, hypercalciuria occur in type 2 also, type 1 also, but renal stone formation occur only in type 1. So this is the renal tubular acidosis type 1. This you could answer because your basic concepts are very clear. Let's go to question 24. We got a 34-year-old nurse. She had been brought to by the friend. She ingested a bottle of aspirin. Oh, why she got? Because she's a nurse. She has a very easy access to the drug like aspirin. 4 to 5 hours before, drowsy but cooperative, lab finding, what we expect. So, bottle of aspirin. This is a question about salicylate poisoning. Agreed? She had taken a bottle of aspirin? Yeah. But what is one more thing, 4 to 5 hours ago? And now she is drowsy. Well, let's learn what happened in salicylate poisoning. When the salicylate, which is a aspirin, which is a acetyl salicylic acid, salicylate are nothing but acid, acetyl salicylic acid. So when they are ingested like that only, immediately it will lead to metabolic acidosis. Why? Again, because I told you itself is an acidic compound. So when the severe metabolic acidosis occur, so immediately pH will fall, bicarb will fall. This will happen immediately. But as we know the basic concept, compensation starts. And what happens in basic compensation? CO2 level will go down. This is a compensation. This is a net result what we are going to get it out of this salicylate poisoning. Okay. So you can say initially there is metabolic acidosis, but later on patient can even have associated respiratory alkalosis as a compensation. This we know the basic. Look into other options. Okay, look into other options. So we have a bicarb of 12. We are getting CO2 20. If you calculate the winter formula, Winter formula is 12 multiplied by 1.5 plus 8 plus minus 2. This is 18 plus 8 plus minus 2, 26 plus minus 2. This comes out to be 24 to 28. This is the what we are going to get it, right? This what we are going to get in this if you are going for adequate compensation is there. So if you look into this, how much we are getting CO2 is we should be in the range of 24 to 28. This is slightly on the lower side, agreed. What about, okay, it looks that here it has been overcompensated. It looks that here it is overcompensated. It has even gone below 24 also. Let's look into other options. What about this? What about this? Here say is an alkaline pH. If it is 24, if you calculate by 1.5 plus 8 plus minus 2, this comes out to be how much? This comes out to be 8. This comes out to be 8 44 plus minus 2, 42 to 46. Here it is in the range of CO2 should be in the range of 42 to 46. This is not the answer. If it is 16, it's again 16. If you calculate 16 multiplied by 1.5 plus 8 plus minus 2, this comes out to be 24 plus 8 plus minus 2. This is 32 plus minus 2, 30 to 34. What we are getting is 34, 30 to 34 is one more, right? One more. What about this? If you calculate. So if you look into this, all are very close. It's a real, very good question. All are quite near to each other. But thing is, there's only one condition out of this where it has gone beyond the calculation. What we learned in the very beginning, normal range, and they want, even if they are going to calculate by winter formula, if they are in the normal range of winter formula, we say it is adequately compensated. If it goes beyond that, it is respiratory alkalosis. And this is the winter formula, range, normal, adequately compensated. CO2 more than above we call as respiratory acidosis. Goes down below is respiratory alkalosis. So friends, classically in case of salicylate poisoning, the step is like this. First, so write down the golden line in salicylate poisoning. First step is immediately metabolic acidosis. Second step is metabolic acidosis with respiratory alkalosis. Finally, it becomes respiratory alkalosis, because by the time that it is getting metabolized and alkalosis occur. So all are equally closely resemblance is there, but if you calculate the only one where it is going toward metabolic acidosis and respiratory alkalosis is this stage where he is in this stage. Metabolic acidosis and respiratory alkalosis is going on, and after some time it will be only respiratory alkalosis. Hence, this is the best answer. Beautiful question, really closely resembling. But one thing, if you know the salicylate poisoning sequence, metabolic acidosis, acidosis with alkalosis, and finally it is respiratory alkalosis. So it is in the border zone of metabolic alkalosis, metabolic acidosis with respiratory alkalosis, and the next step is respiratory alkalosis. It is somewhere quite about to enter into this range, hence this is the best answer. Well, what are the commonest cause of acid-base disturbance in the European countries? European countries means London, Paris, New York, Washington. Okay, what are the commonest cause? Quickly, I hope you have right the answer. Well, I'm sure most of you have gone for alcohol is the answer. But I'm sorry, it's the most common wrong answer. Answer is diarrhea. Diarrhea? European countries? Yes. Why this the answer? The moment you think that acid base in European countries, you think about, I told you, Paris, London, okay, some other Western countries, and in Western countries, alcohol is very common to be used. They consume liquor as we in Indian subcontinent or Northeast, Southeast Asian country, we consume tea. They consume liquor, is in the culture. But one thing we forgot. So what we presume that we have a person who have taking liquor, you go for alcohol. But one thing you forgot, it is a methanol. What we call in India as kachi sharab or desi sharab or tharra. That lead to problem of metabolic acidosis. Alcohol doesn't use to ethanol, what is drinking, that is usually not a cause. It's a methanol is the cause. Okay. But what we think, the moment you get a European person, a white color skin person come to our mind and he must be taking liquor, and we go for alcohol is the answer. And I told you alcohol is the most common wrong answer, ruled out. Agreed. Now just think, one of your friend from the subcontinent country has gone to France and he's sitting in the Eiffel Tower and he's taking tharra, desi sharab. So what you will say? Arey dada, yahan par bhi aake tharra pee rahe ho? Ya France mein aake koi champagne, wine, shine piyo. Am I right? And what you tell your friend, agar tharra hi peena hai, तो फ्रांस आने की क्या जरूरत है, इंडिया में ठीक थे, है नहीं है. So now what about diarrhea? In diarrhea there is loss of bicarbonate occur and that lead to metabolic acidosis with normal anion gas. Diarrhea occurs to European people also. उनके नीचे कोई नट बोल्ट नहीं लगे हुए हैं कि उनको डायरिया नहीं होगा. Diarrhea occurs to European people also. So the commonest cause of acid-base disturbance in the whole world is diarrhea or gastroenteritis. You can say something like that also. Friend, this is the gold medal getting question. To those who could not understand Hindi, briefly in summary in English, that that it is the methanol poisoning which lead to acid-base disturbance with not by the ethanol, and diarrhea causes loss of bicarbonate that can lead to metabolic acidosis. It's a gold medal question, don't forget it. Okay. So diuretic is the topic of discussion now. I have a question for you. We have a 57-year-old man, systolic heart failure. He is taking furosemide. Still functional impairment is there. Ejection fraction is 30%, and he is given additional diuretic as spironolactone. Okay, this is going to decrease in which of the following? The answer of this question is A. Why the answer is A? Why not others? This you will never understand unless you know the basic concept. Okay, the answer is A. So before I go for the discussion about diuretic, question only for the student to answer. What is a diuretic? And second question is, which of the following diuretic act at descending loop of Henle? I give you 30 seconds to think and answer that what is a diuretic and which of the following diuretic act in the descending loop of Henle. Quickly write down. Rather, I give 1 minute to write down the answer quickly. So I hope you have written the answer. Well, there are two things that you should know the basic concept. Many of you may have written that diuretic is any drug which causes increased urine formation. Quite possible. It's the most common wrong answer. Second thing regarding this question, quite possible that you may have written this answer. The answer is none of the above. Don't worry. Don't worry, this you will never understand unless you know the basic concept. Now, what is a diuretic? Which is any drug? The usual people think that any drug which causes increased urine formation is a diuretic. No way. Well, somebody takes a bottle of beer, and after taking beer, the person passes lot of urine. So you may say beer is a very good diuretic? No way. If beer was a good diuretic, then suppose I sit in the OPD and a patient of hypertension with CHF come to me, congestive heart failure, where I have to give a diuretic. So I would have written like this: you take one bottle of beer in the morning at 9 a.m. The patient will say, oh, Doctor Saab, what will happen with one bottle? No, make it BD or TDS. He will force me, no, make it TDS 3 times a day. Kuch sham ka jugaad bhi banao, make something for the evening also. How will I pass my time? Okay, I will say, okay, TDS. The patient would have been very happy, and of course, everybody will be very happy. This is not the answer. So definitely. So what's the answer? And why not? Descending loop of Henle. Sir, fusamide. Fusamide act on the ascending loop of Henle. So this we will never understand unless we know the basic. So let's learn the basic. This you have to learn. So in the basic, first of all, we learn what the normal physiology. And then I'll go for pharmacology, I'll integrate, and of course I'll come to pediatric and medicine also. So first we learn about normal physiology. The normal physiology goes like this. This is a PCT. In PCT we know that sodium and water is reabsorbed. I'll confine to what is needed at my talk. So here sodium and water, and this is the PCT. This part, so-called descending loop of Henle, is permeable only to water. It's this part where sodium is not absorbed. And this is the ascending loop of Henle, where only sodium is absorbed, water is not absorbed. This is so-called proximal part of DCT. Proximal part of DCT, or sometimes they also call as distal part of ascending loop of Henle. This is ascending loop of Henle. This is distal part of proximal part of DCT. Here only again sodium is reabsorbed. And this is the distal part of distal part of DCT, and this is the collecting tubule. The collecting tubule. Here, sodium is absorbed with water under the influence of aldosterone. A for aldosterone. This is the normal physiology. Point to be noted that, again going to basics, point to be noted that here we are getting only sodium and water reabsorption in PCT. In descending loop of Henle, we have a descending loop of Henle, only water is reabsorbed. In ascending loop of Henle, sodium is absorbed, only no water. In proximal part of DCT, only sodium. Distal part of DCT and the collecting tubule, sodium but under the influence of aldosterone. This is the normal physiology in relation to sodium and water. So now when we say diuretic, a diuretic is anything. Write down the definition of diuretic. A diuretic is a drug which inhibits sodium reabsorption at any part of the nephron. So now if sodium is not absorbed, water will also not be absorbed. Water always follows passively. So sodium not reabsorbed, water need not reabsorbed, and that will lead to increased urine volume. So now you write down the definition of diuretic. A diuretic is a drug which inhibits sodium reabsorption. A diuretic is a drug which inhibits sodium reabsorption at any part of the nephron. At any part of the nephron, thereby water is also not absorbed. Thereby water is also not absorbed, and that results in increased urine volume. A diuretic is a drug which inhibits sodium reabsorption at any part of the nephron. Thereby water is also not reabsorbed, and the net result is increased urine volume. This is a diuretic. With this background of basic understanding, now we come to the pharmacology. Let's correlate. Let's learn about pharmacology of the diuretic. So friends, now which diuretic act at the PCT? The PCT we know very well, these two, acetazolamide and mannitol, they act at the PCT. Which diuretic act at descending? None. Why none? As per definition, it should inhibit sodium. It is this part, there is no sodium reabsorbed. So there is no question of diuretic acting at this step. It is this everybody knows. This is furosemide, or so-called loop diuretic, for which example of furosemide. This is known to everybody. This is the part where thiazide act. Thiazide, they act in the proximal part of DCT, and this is the place where spironolactone, that will be acting in the distal part of DCT and collecting tubule. We know spironolactone is a aldosterone antagonist. It is a aldosterone antagonist. This again is known to almost all of you. So this is the answer of question what we have, right? So with this background, so we go back to the question once again. Which cause decrease in the following? Spironolactone. So what we do normally sodium are absorbed with water under the influence of aldosterone normally. And we also know that 2 positive have come, 2 positive will go out normally. So if you are using aldosterone antagonist like spironolactone, this will inhibit aldosterone. Aldosterone inhibited means sodium will not be reabsorbed. This is the definition of diuretic. If sodium will not be reabsorbed, so H ion will remain in the body, that lead to acidosis. Less H ion will be secreted. This is what the question is there. Decrease H ion secretion and it will lead to hyperkalemia. That's why a very commonly asked question, spironolactone, wonderful drug, but they can lead to hyperkalemia. Or that's why we also call them as potassium sparing diuretic. We call as potassium sparing diuretic. This is the reason. Due to same reason, they should not be given in chronic renal failure. Usually, because if any condition where the potassium level is high, sorry, okay, in CRF potassium level is high, so that's why it should not be given or used very cautiously. Similarly, they should not be used with ACI, because ACI are well known to cause hyperkalemia. So friends, any condition where hyperkalemia is there, they should not be used. Let's look into other options. So we are clear about it. It causes a decreased hydrogen secretion from collecting tubule. Agreed. What about PCT? No way. They don't act at PCT. They act at the collecting tubule. Co-transport. This is the where furosemide act. Ascending loop of Henle. We just learned it's the loop diuretic or furosemide they act. PCT. No way. Urea absorption in collecting tubule, it is done by the ADH. Most of us are aware that ADH is they absorb water. This is known to 100%. But 90% students are not aware that ADH also reabsorbs urea in collecting tubule. Okay, so by direct technique and by rule out technique also, now we are clear about it that potassium sparing diuretic, they are acting in the collecting tubules. Well, little bit of biochemistry also. This you should know. This you should know more about biochemistry. Let's integrate our biochemistry with physiology, with pharmacology, with medicine and pediatric. Let's have an integrated approach because these are common questions. So let's learn what happened. What happened, right? What is the mechanism of action of renin, ACI, etc.? Normal physiology. So whenever there is decreased renal blood flow, any condition, the renal blood flow is reduced. Classically, this happens in condition like hypotension. Like hypotension, low BP. So definitely the renal blood flow is reduced. So that will lead to what? This will lead to what? Reduce. There will be reduce glomerular filtration rate. Definitely, renal blood flow is no blood in the kidney, the filtration will go down. And this will lead to so decrease GFR. It activates macula densa. In the physiology, everybody knows that in macula densa, we have a renin. So renin is secreted due to come from which place? Macula densa. Okay. So now this macula densa in the normal physiology will convert angiotensin which come from liver. This is important question from physiology. Angiotensinogen is made in the liver, and this renin will convert angiotensinogen into angiotensin 1. So this is angiotensinogen and this is angiotensin 1. Angiotensin 1. Now this angiotensin 1 is normally converted into angiotensin 2 by ACE, and this comes from the lung endothelium. Point to be noted. Very, very important question from physiology. This is the place where student gets stuck up in the physiology. Okay, so friends, angiotensinogen is made in the liver, and it is the renin which will convert angiotensinogen into angiotensin 1, and this angiotensin 1 is converted into angiotensin 2 by ACE, and this comes from lung epithelium. Now this molecule, this is the most powerful, it's a very powerful vasoconstrictor. It is not the most powerful, but it's a very powerful vasoconstrictor, and that is going to cause increased blood pressure. Anything, we know that when the vasoconstriction will happen, this will cause increased blood pressure. Why? It's going to increase the peripheral resistance. It's going to cause increased peripheral resistance. Little bit more basic physiology about BP. We all know that BP, physiology, basic concept, physiology, BP is stroke, is the cardiac output multiplied by peripheral resistance. Make a box of this line, very, very peripheral resistance. So this is going to cause a vasoconstriction that cause increased peripheral resistance, BP will go high. Now we correlate this physiology with pharmacology integration. So whenever we use ACEI, when we use ACEI, this will lead to reduced formation of angiotensin II, and that will lead to reduced peripheral resistance. BP will come down. That is the basic pharmacology why we use ACEI to reduce blood pressure. So we come back to angiotensin II, which has caused vasoconstriction. It also tend to retain sodium by direct action. So this is going to cause increased sodium. Increased sodium will lead to increased BP. It also causes increased aldosterone production. This will lead to again increased sodium retention. It will lead to increased BP because they are going to cause increased blood volume. Increased sodium will lead to increased blood volume, and increased blood volume will contribute to increased blood volume. So this will lead to increased BP. So ultimately aldosterone is increasing BP by three mechanisms. Increased sodium and increased aldosterone, by this blood volume is increasing, and by this they are causing increased peripheral resistance is increasing. So that's why once we use ACEI, they reduce blood volume and they reduce peripheral resistance, the BP comes down. Now I am sure your concept about physiology, pharmacology, biochemistry, pediatric and medicine all are integrated. Now you know that in the medicine why we use ACEI to control BP and to control congestive heart failure, because they are going to reduce blood volume also. This is the integration of physio, biochem, pediatric medicine and pharm. So with this background of all basic concept, we go to the next question. Is Tanya, a 22-year lady, and she has a feeling of lightheadedness, and she lost her mother about 5 months ago. Decreased appetite, lost 6 kg, missed 2 menstruation cycle. BP on standing is 80/55, supine is 102/72, pulse is increased on standing, supine pulse is 87. Sodium is 128, potassium 2.8, severe hypokalemia is there. Sodium, urine sodium is increased and potassium increase. Oh, what is this? And skin dry and mucosa dry. So there are few things that we got to know. One is skin dry, mucus dry. This simply tell there is reduce water in the body. She is dehydrated, to be more precise. Sorry. The one is that she is dehydrated. And she's now, second point, she's severely dehydrated. How come? Her BP in supine position is 102/72, standing is 80/55. That means she has a postural hypotension. Postural hypotension means BP falls on standing. And there are two very, very important causes of this. One is anything where there is autonomic neuropathy, that can lead to postural hypotension. Second is anything which lead to reduce intravascular volume, which is typically seen in any dehydrated condition. In our question, we are getting dehydrated. How do you know skin is dry? So one thing is very clear, that we are dealing with something which had reduced intravascular volume is there. Moreover, it has led to low sodium, hypokalemia, and urine sodium and potassium is increased. This occur with any use of diuretic. Any use of diuretic like furosemide, that can lead to increased urine formation, that can lead to hyponatremia, hypokalemia, increased urine sodium and potassium. Okay, so the answer of this is diuretic abuse. But why she is taking like this? Her mother died 5 months back. She is totally mentally disturbed. So under the stressful condition, what we note, how do you know stressful condition? She missed her 2 menstrual cycle also. Well, you can very well say she can be pregnant also. We cannot rule out. But but in the question there is nothing like related to pregnancy. Moreover, in pregnancy, postal follow BP or profound dehydration will not happen. Okay. So, but in diuretic use, maybe furosemide, all the findings what I mentioned, hyponatremia, hypokalemia, increased urine sodium and potassium, all will be there. What about other options? Cerebral salt wasting. Cerebral salt wasting is another condition which can be a possibility in these cases. But in cerebral salt wasting syndrome, menstrual loss is not a feature. And moreover, this tend to occur in any condition where there is a head injury is there. It's usually after some injury or some roadside accident this occur. In our case, there is nothing like head injury, nothing like roadside accident. Self-induced vomiting. Self-induced vomiting will lead to loss of hydrochloric acid. Hydrochloric acid will lead to metabolic alkalosis. Okay. Metabolic alkalosis can be a finding, but in this there is nothing like any acidoalkalosis, no mention, there is no history also. Low calorie intake will not lead to dehydration. And mineralocorticoid deficiency, which typically occurs in Addison disease, okay, in this hypernatremia occurs, or rather there is hyperkalemia occurs. Hypokalemia is not a feature, that is ruled out. So all are ruled out. Only thing what left is diuretic abuse is a very common thing, especially in the Western countries. They have all this sort of problem which can lead to all what we discussed just now. So it was a good question to discuss. Basic are needed. We got a 72-year lady, diabetes, hyperlipidemia, hypertension, non-displaced fracture of the femur or humerus 3 years back. She's on furosemide, thiazide, low-dose prednisolone, which can cause decreased amount of calcium excretion. Answer is thiazide. Okay. Now thiazide. What we know, they act at what? They act in the proximal part of this DCT, but they cause reduced calcium excretion. Of course, they do cause increased sodium and water loss. That's a definition of all diuretics, but they cause reduced calcium excretion. This is in contrast to furosemide, which act on the ascending loop of Henle. They also cause increased loss of sodium and water, but they also cause increased calcium loss in the urine. In nutshell, they lead to hypercalciuria and they lead to hypocalciuria. In other way around, since they are not causing calcium loss in the urine, so in the blood they lead to hypercalcemia. They raise the calcium level in the blood. And as far as furosemide, we use in the treatment of hypercalcemia. Very, very important point. Furosemide is a treatment of hypercalcemia, and thiazide, they are the cause of hypercalcemia. So if we want to prevent osteomalacia or bony problem, we tend to use thiazide. Furosemide, this causes calcium, so it will lead to increased calcium. Prednisolone can also lead to increased calcium loss, but they are going to destroy the they are going to cause osseous matter loss also. Okay, increased loss. So we want to save the calcium, you want to save the bone, then thiazide is the one thing. So thiazide, they lead to hyponatremia, metabolic alkalosis, hypokalemia and hypocalciuria. These are the classical findings that we see in diuretic, especially this is the one. And one more thing that happen in the thiazide, they lead to increased blood sugar also. They are the important cause of hyperglycemia also. So friends, cannot afford to forget hyponatremia, metabolic alkalosis, hypokalemia, hypocalciuria and of course hyperglycemia. One more thing, all diuretics, they tend to retain uric acid. That means all diuretic, they precipitate gout. So all diuretic, they precipitate gout. So in gout patient, diuretic should be avoided because it's going to precipitate gout. About which, what are the main side effects? They can lead to dehydration, hyponatremia, hypokalemia and hypercalcemia. I mentioned previous slide, gout and impaired blood sugar. All what I mentioned in the previous slide are the side effect of thiazide diuretics. Least likely to cause diuretic, the next question. Well, lithium. This is a diuretic, should not be used. This is a diuretic, should not be used. Pyrazinamide is a drug that we use as an anti-tubercular treatment, ATT. Is a well-known cause of increased uric acid. Should not be used. Alcohol is a well-known cause of increased uric acid, should not be used. So all are ruled out. Lithium is the answer. In fact, in the good olden days, in the 19th century, lithium was actually used to treat gout in the previous, well, so now it was very old, maybe more than 100 years, more than 150 years back it was used to be. But now lithium itself is a very toxic drug. We have got better molecule, but one thing is there, least common is lithium. But now I have a gold medal question for you. What I generally made that we don't use any diuretic in case of gout. But suppose there is one patient of gout to whom you want to give diuretic. Which diuretic you can give? Write down the answer. It's a gold medal question. Gold medal top rank question is this. Quickly write down. Well, the only diuretic that we can give in this patient is tynelic acid. Okay. Rank, you want to get top rank in any exam. These are the questions which will take you to top rank. Tynelic acid. Well, we got one more question. We are getting a 4-year-old child. Failure to thrive, generalized weakness, BP is normal, sodium 137, potassium is low, urea, creatinine, bicarb is increased, we are getting hypokalemia, and we are getting metabolic alkalosis. Metabolic alkalosis. Most likely diagnosis is Bartter syndrome. Why this the answer? Why not others? Let's learn the basic concept about Bartter syndrome. First of all, here the catch point is BP is normal. In Cohen syndrome, BP is high. Cushing syndrome, BP is high. BP high, BP high. In all the other conditions, BP is high. So very comfortably we ruled out other options. And this one condition with the way the BP is normal. Right? So let's learn about basic concept about Bartter syndrome. Okay. And Bartter syndrome, I'll make you revise only in 1 second. In 1 second only. But before that, basic concept. And in this basic concept, we will correlate physiology, pharmacology, pediatric medicine, so many things, and pathophysiology also. So we go back to the basics. We know that in ascending loop of Henle, this part is permeable only to sodium. And we also know that in loop diuretic, when we loop diuretic, they inhibit sodium reabsorption at this place. So let's extend our knowledge of physiology to more detail about pharmacology of the loop diuretic, and we'll correlate, we'll integrate. Suppose we have to one patient, we have given furosemide, which is a loop diuretic, sodium not getting reabsorbed, and large amount of sodium and water will come to collecting tubule and density. Sodium is a very, very precious ion. Body can't afford to lose sodium. So normally what happens? Normally 2 sodium are reabsorbed with water, and this is the aldosterone that we know very well. And as we also know, 2 positive particles have come in, and 1 H ion and 1 potassium will go out. That we know normally. Now when we have used a loop diuretic, which has caused excess amount of sodium to come to collecting tubule, and I told you, sodium is a very, very precious ion. Body can't afford to lose sodium, the body will secrete more and more aldosterone. So it will lead to secondary hyperaldosteronism. Secondary hyperaldosteronism. So now maybe 4 sodium have been reabsorbed. Initially 2, now 4. But don't forget, 2 extra sodium have come in, body has to throw out extra HI and extra potassium. So sodium has come in with water, but double HI and double potassium has gone in. So due to loss of HI, it will lead to metabolic alkalosis. Potassium goes out, that lead to hypokalemia. So friends, when we use loop diuretic like furosemide, there occurs hypokalemia, there occurs metabolic alkalosis, there occur increased aldosterone secretion, okay, BP is normal. BP is, when we use furosemide, it will bring the BP to the downside because we are losing, so BP will try to be going down. So this is the basic finding that we get in case of furosemide, right? So now you are getting confused why I'm talking about loop diuretic when the topic of discussion is Bartter syndrome. Yes, it is true that it's a topic discussion. So friend, in Bartter syndrome, this congenital defect of sodium reabsorption at ascending loop of Henle. Write down. So in Bartter syndrome, it's a congenital defect of sodium reabsorption at ascending loop of Henle. It means Bartter syndrome will have everything same as loop diuretic. They will be having increased aldosterone, and they will be having hypokalemia, metabolic alkalosis, polyuria will happen. When we use loop diuretic is a very powerful loop diuretic. Now you may be getting confused, sir, if aldosterone has already come, it has absorbed all sodium and water, then why sodium water will go out? Then how can loop diuretic act like a diuretic? Yes, you have a very valid question to ask. Now again, basic concept. Suppose loop diuretic has inhibited 100 molecules not to be absorbed, and these 100 molecules, they come to DCT and collecting tubule. So 100 extra sodium particles have come in the DCT or collecting tubule. But don't forget, aldosterone is a weak hormone. It cannot reabsorb 100. Maybe it can absorb 20. Still, 80 sodium will go out with water. 80 sodium and water will go out, and they will have polyuria. Got it? And that's why furosemide act like a diuretic. So friends, now we understood why polyuria will happen in these patients. Moreover, potassium level going down, that lead to muscle weakness. And this is secondary to low potassium level. And finally, in case of Bartter syndrome, they are autosomal recessive condition. And autosomal recessive condition, so BP is normal. BP is not reduced. So friend, this is the golden line to remember. So I can also write very comfortably, and as I promised that I'll revise the entire Bartter syndrome in 1 second. So write down, Bartter syndrome is equal to furosemide. Write down, the Bartter syndrome is equal to furosemide. Bartter syndrome is furosemide. So entire Bartter syndrome is squeezed in one word, golden line to remember. So all the golden line you must remember them very comfortably. And one more thing, don't forget that furosemide causes hypercalciuria, and that we see in Bartter syndrome also. In hypercalciuria occurs in Bartter syndrome. Understood? So we are clear about why our question was there. So all the features are Bartter syndrome except polyuria occurs, metabolic alkalosis occur, periodic paralysis, this occur due to hypokalemia. Hypokalemia, which is a feature. Hypokalemia, yes. Low aldosterone, no. Aldosterone level is high. Aldosterone level is high. Okay. So one more important point that you got to know. In Bartter syndrome, we are getting secondary hyperaldosteronism. Definitely, Bartter syndrome, or when we use in loop diuretic also, the aldosterone, the what in call as secondary hyperaldosteronism. So Bartter syndrome is the one condition where secondary hyperaldosteronism occur. But secondary hyperaldosteronism occur in condition like congestive heart failure, nephrotic syndrome, etc., where we have secondary hyperaldosteronism. But in this condition, edema of feet occurs. And now comes the gold medal question. One condition where secondary hyperaldosteronism occur without edema is Bartter syndrome. Bartter syndrome, secondary hyperaldosteronism without edema, cannot afford rank number 1 in any exam throughout the world. Other condition where we have secondary hyperaldosteronism without edema, Gentleman syndrome and gastroenteritis. G stands for gastroenteritis, maybe diarrhea, maybe vomiting. So in this condition again, so 3 conditions where we have secondary hyperaldosteronism without edema of feet, gold medal question are this. Okay, this is not known to 99% students are not aware of this point. So we got an answer. We got another patient, 24-year-old lady, weakness, cramps, renal stones, sodium is slightly reduced, potassium reduced, bicarb, metabolic alkalosis, urea is slightly increased, creatinine is increased, calcium level is almost in the normal range, phosphate, magnesium is low. Oh, what is this? What is this? Okay. What is this? We are getting low magnesium level is there. And we die. Oh, Gentleman syndrome is there. Let's learn what is going on. One very important finding we are getting is hypomagnesemia is there, right? Answer this question is Gentleman. So let's learn about Gentleman syndrome. Basic concept. The basic concept is that this is the nephron. Basic concept of Gentleman syndrome. This is the proximal part of DCT where thiazide diuretic act. What they do? Normally, they inhibit sodium reabsorption at distal part of DCT, and here only sodium is reabsorbed. When we use thiazide, they inhibit sodium reabsorption. Again, large amount of sodium comes here. Again, body will try to secrete large amount of aldosterone. Same process what happened in furosemide. There is secondary hyperaldosteronism. and that would try to conserve sodium and water. It's exactly same what we happen in furosemide. So it will lead to what? Low potassium. It will lead to metabolic alkalosis. Exactly same. It will lead to polyuria. It will lead to polyuria also. This is what happened when we use thiazide. Now, in Gentleman syndrome, there is congenital defect of sodium reabsorption at this place where the thiazide is acting. So we can say Gentleman syndrome is same as thiazide. Thiazide. Okay, thiazide diuretic. And thiazide diuretic is same as Gentleman syndrome. So in Gentleman syndrome also, now additional finding, they are recessive, just like same as Bartter syndrome. They also lead to muscle weakness. They also lead to muscle paralysis, but they lead to reduce. They cause magnesium, increased magnesium loss in the urine. They lead to increased magnesium loss in the urine. It's a classical finding that we get. Classical finding, and of course, they increase magnesium loss in the urine is a classical finding that we get in Gentleman syndrome, and they also cause reduced calcium excretion in the urine. They cause reduced calcium excretion in the urine. The point to be noted: the one difference between Bartter syndrome and Gentleman syndrome is regarding calcium loss. Calcium loss is more in furosemide and less in case of Gentleman syndrome. Right, sir. Least common feature in Gentleman syndrome: hypokalemia occurs, metabolic alkalosis occurs, hypocalciuria occurs, hypomagnesemia occur because they cause lot of magnesium losses there. So serum magnesium level goes down classically in Gentleman syndrome. Hypertension is not a feature. In both Bartter and Gentleman, BP is normal. This again autosomal recessive condition, right? So in Gentleman syndrome, normal BP, hypokalemia and hypocalciuria, but increased magnesium loss in the urine, and that lead to low serum magnesium level, so-called hypomagnesemia. Hypomagnesemia is the feature. Right, sir. So child with the alkalosis, hypertension and hypokalemia, what can be the cause? This is Liddle syndrome. What is this Liddle syndrome? Let's talk more about this basic concept. Basic concept goes like this. Yeah. So normal physiology, we all know in the DCT we have a aldosterone which causes sodium to be absorbed, and water comes in, and what goes out H ion, and what goes out is potassium. This is normal. Liddle syndrome, the aldosterone level is reduced. The aldosterone level is reduced. So what do you expect in this? Definitely less sodium should be absorbed. Obviously we know the basic physiology. If the less sodium is absorbed, H ion will not go out. There will be increased H ion in the body, acidosis. Potassium will increase, that lead to hyperkalemia. Yes, there will be hyperkalemia will be there, and there will be metabolic acidosis. But to your surprise and my surprise, in this condition aldosterone level is reduced, but there is excess of sodium reabsorption, and water will also come in. Very funny. How can be? Yes, it is there. Excess of sodium and water has come in. It lead to increase intravascular volume, and this will lead to increased blood pressure. It's the basic mechanism why BP increases in these patients. Now excess of sodium have come in, there will be excess of H ion and excess of potassium loss will be there. Yes, it is there. Why? Why is it so? We know the basic concept that double sodium have come in, double H ion and double potassium will go out. So excess H ion goes out, lead to metabolic alkalosis, and excess potassium goes out, lead to hypokalemia. Okay, so in Liddle syndrome, which is again but it is a autosomal dominant condition. The previous two were recessive, and here hypertension is a feature. But hypokalemia occurs, there is metabolic alkalosis occur, and the BP is high. This is the thing that you got to remember. Classically, golden line to remember is this. If you remember this, everything is fine. But you are going to ask me a question, but how come, sir? How is sodium getting reabsorbed? Oh, yes, that's $1 million question. So let's learn. So go back to basics, basic physiology. We are getting sodium reabsorption with aldosterone, with water. Normal. But many of us are not aware. There are certain channels from which sodium can be reabsorbed without aldosterone. And they are known as epithelial sodium channel. ENAC, full form is epithelial sodium channels. From this, the sodium can be reabsorbed without aldosterone. Well, I can give you a day-to-day example. We all travel in trains, and you are a thorough gentleman, citizen of the country. You take a ticket. You buy a ticket, but we all know, especially in India and the subcontinent countries, many people travel in the train without ticket also. They enjoy all that journey, and what they do, they say, oh, TT se set kar liya hai. They do some setting. If the ticket cost is 500 rupees, they give 100 rupees to TT. TT is happy, passenger is happy. They are traveling without tickets. The same thing here, they are traveling without tickets. Without tickets, no aldosterone. But rest all is what has to go by law of electrostat. H ion will go out, potassium will go out, and that will lead to so-called hypokalemia, metabolic alkalosis will happen. So understood? This is Liddle syndrome. So if you go back to our basic question, we are getting hypertension, alkalosis. We don't get increased BP. Fanconi also don't have increased BP. In Gordon, BP is high, but there is hyperkalemia. So here we have a hypokalemia. So this also rule out. So friends, this is the golden line to remember regarding Liddle syndrome. Remember this much is good enough. All are true about Lidl except alkalosis. Yes, they respond very well to amiloride. Amiloride is a potassium sparing diuretic, but it does not need aldosterone. It is the treatment you can add it on. The treatment of choice for this is amiloride. Hypertension occurs recessive? No, it is autosomal dominant condition. Hypokalemia? Yes. The point to be noted, the first two are recessive and this Lidl syndrome is dominant. Which of the following is known as pseudo-hypoaldosteronism type 2 is Gordon syndrome? Well, what is Gordon syndrome? Let's learn the basic concept. Basic concept about Gordon syndrome. This is not known to 99.9% students are not aware of Gordon syndrome. And it is this condition where chloride shunt occurs. What is this? Let's learn the basic concept. This is the nephron. Yeah. Normally, again aldosterone comes, lead to sodium absorption, water absorption, H ion goes out, potassium goes out. This I already have written, but I have to write every time just to make your fundas clear. Now in Gordon syndrome, aldosterone level is reduced. So again, aldosterone level, but still excess of sodium is reabsorbed. Excess of sodium with water. There are two, these are two normal come, this normal. Okay, this normal, this all happen normal, but here excess sodium coming on. Why? Same epithelial sodium channels. Agreed? You mean to say same as Lidl syndrome, bit, not complete, but there's something extra. In Lidl syndrome, only sodium went in. Here sodium is going in. But in addition to that, excess of chloride also comes in. Excess of chloride has also come in. Let us presume 6 molecules of chloride have entered the body. Agreed? So there are 4 sodium, 2 and 2 sodium have come in. 4 sodium have come in. Agreed? 4 sodium has come in, but 6 negative particle has also come in. It means in the body, the net result is increased chloride, more negative particle. So point to be noted, 4 sodium have been absorbed, and in normal process excess of H ion and excess potassium should go out, but cannot, because these H ion and potassium they will be excess of H ion and potassium they will be neutralizing this extra chloride. So H ion will remain in the body, that lead to acidosis. Potassium will remain inside, that lead to hyperkalemia. So friends, write down Gordon syndrome. It is autosomal dominant condition. Hyperkalemia, metabolic acidosis, and increased BP. Why? Increased sodium and water reabsorb the way in Lidl syndrome. BP will be high. Okay, BP will be high in this condition. There will be hyperkalemia, metabolic acidosis, and aldosterone level is reduced. Righto? So friends, now you are, and this is also known as pseudo-hypoaldosteronism, right? Aldosterone level is reduced, but still we are getting high BP, pseudo-hypo. And finally, the chloride shunt is operating in Gordon syndrome. And now come the gold medal question throughout the world. tell me any condition you know of, any drug which causes hyperkalemia due to chloride shunt. The question is, tell me any drug you know of which causes hyperkalemia due to chloride shunt. You mail this question to me. The email ID I'll give you. This rank number 1 question is there. Okay. So friends, now I give you golden line to remember. I give you summary of all the 4 syndromes. Summary of all the 4 syndrome we just studied. We talked about Bartter syndrome. We talked about Gentleman syndrome, Liddle syndrome, and Gordon syndrome. Summary. Summary is potassium, reduce, increase. Metabolic, alkalosis, acidosis. Okay, then polyuria. Yes, no. Inheritance. Recessive, dominant. Okay, dominant is the aldosterone level. Increase, reduce. This is the summary of all these 4 syndrome. Summary. In Bartter syndrome, so we have these potassium reduce, metabolic alkalosis, polyuria, recessive, aldosterone increase. This is a summary. Now I give you summary of this summary. Write down. Summary of the summary. Summary of the summary. We'll make summary of the summary also. So only condition which is where, in condition where we have a hyperkalemia, metabolic acidosis, only condition is Gordon syndrome. Condition with increased BP, reduced aldosterone level, autosomal dominant, they are Gordon and Liddle. So summary of the summary you can revise only in 2 lines. Okay. So I hope you are clear about all these difficult syndrome. Well friends, the next topic of discussion is sodium. But my staff has told that they are getting message the class is already extended and this will again need a lot of time. So I hope you all enjoyed the class. So what I am thinking that I'll be taking regular T&D classes and the next topic is nephrology. So I'll be covering this topic with the next. Okay, because study should be a fun, it should not be a punishment. But you all must have read it, the question. Don't worry, this question I'll be including in the next exam. Okay, so because this will again take 1 hour, so, but I don't want it should be very heavy class, right? But don't worry, I'll be doing in the next T&T. So I hope you learned a lot and enjoyed also learning with entertainment. How was the class? Do give feedback. This is and of course you have to answer the question also. Dr. Bhatia at dbmi.edu.in to give feedback. One thing is there, many of you must have learned today, if you really want to top in any exam in the world, your basic concept should be very, very clear. And now you will agree with me that in most of the medical colleges, our basics are not taught. With the result, our foundation is very weak. Okay? So one thing, Guru Mantra from me, make your basics very, very strong. So now what I taught you, I gave you golden lines. You read those golden lines. And you can very well, the entire lecture you can revise in 2 minutes. And this one topic which is the least known to most of students, that you will agree with me, but now your concepts are absolutely clear. You can appear for any exam in the world, the point I'm saying again and again. Now, I gave you one example. I say that basics should be very strong. If your basics are strong, you can write any exam in the world. What do you mean by? Suppose you use specs. Most of the medicos, you use specs. I also use. Now, with the specs, you can read newspaper, book, TV, movie, football match, etc. You can see, watch. But if you lost your specs somewhere, you misplaced. Can you read this? No. But once the specs come, then things become very easy. So friends, guidance to all of you, make your basic concept very strong. Most of students commit mistake, they just straight away jump to MCQs without knowing the basic concept. So this is my way of teaching, that you make basic strong. I give you specs, that's all. Then you can write any exam in the world. They are not going to ask you anything what I have taught you. So next time when you are using the specs, of course you are using right now also, but you remove the spec, then you know the importance of watching everything using the glasses. Like integrated approach is essential. When I'll be teaching you HIV, I'll be covering you all these. Today also I covered physiology, biochemistry, of course pharma also, medicine, pediatric, etc. what are relevant. So this is the idea of so-called integrated approach. The next TND will be on 17 January, same time. Nephrology, including electrolyte also, sodium potassium also, I'll cover it up. Sorry, I could not cover today. And you'll be you have to get a separate link with which my staff will be providing to all of you. Many of you have not enrolled. Please get enrolled by filling the Google form. We have very many free videos for you to watch. Okay. And in fact, I have recorded the whole medicine lecture in an integrated way, including everything A to Z. Very good, amazing, best in the world. We have certain free sample. You can very well download in our e-Gurukul application. Detail you can see, and it has been sent to you also. And many of you who have not registered with us on Google, please do get registered, so that we'll be sending you lot of information, videos, coming events, etc. will be sending you. I have also written a book, Medicine Simplified, which is known as Mini Harrison Simplified. Ultimate book, very well read, and this is available on Amazon. Just go and type for Medicine Simplified by Dr. Mukesh Bhatia. Okay. Well, my aim of training to you is, I want to convert you from an ordinary star to the moon. There are millions of stars in the sky, but only one moon, and that one moon is you. And that is only possible when you are ahead of others. And today after the class you will appreciate, yes, this is what I want, and after that I don't need to read any book. This is more than enough. Okay. I want to make you a bird like eagle. It flies above the sky, above the clouds. it can survive from minus 45 to plus 45. Why? Its body is made in such a way, in such a way, such a design body, it can fly above the clouds also. If you are going to the air by aircraft anytime, next time you can see that this eagle is flying above the clouds. Same thing, my idea is to make you like this. Your basics are so strong, your confidence level will go very, very high. Okay, friends, champions are not made, they are not born, they are made. They are made by proper training, proper training. Arjunas are not born, they are made. And this earth doesn't lack in people who want to become Arjuna. They don't get Dronacharyas. So friends, I will train you to the best to become eagle so that you are comfortable. Tomorrow is your exam. Today in the evening 6 to 9 you are going for a movie. Why? Your confidence is very, very high. So my idea is to convert you into a car. Rolls Royce is a dream car for everybody, and that is what I want. You from an ordinary car, you become like this. This my aim is. Okay. So I hope you all enjoyed class. Don't forget to send me the feedback. And if you have any query to ask me, you are free to ask me the queries also. Now, one question, why not in the class? Because in the class, when we start getting a lot of questions, that disturb the rhythm of the class also. And today also some technical problem do occur, but that may part of the game. Anyway, thank you very much. I also enjoyed. I hope you also enjoyed. And don't forget to send a feedback. And you want free videos, do mail to us. We'll be sending a lot of free videos. Thank you very much. God bless all of you.